Welcome to another episode of Winning Healthcare Food Fights. I hope you join me, Hunter Schultz, each week as we bring more clarity and understanding to health and wellness without the mess. On this episode, we'll learn from a primary care physician who is on the front lines of today's primary care crisis/catastrophe, why she stepped away from the current system and opened the door to a new way of caring. And with over 10 years of experience and now with her own practice in Woodland Hills, California, she graduated medical school and did her residency at Thomas Jefferson University. She's board certified in family medicine by the American Board of Family Medicine. Dr. Aimee Ostick
Hello.
of Health and Healing Direct Primary Care. Welcome to the show.
Thank you so much for having me. This is really exciting. I'm really excited to talk to you about something that's obviously filled my life in the past couple of months since I've opened. So I'm so excited. Thank you.
Well, I read that you just surpassed 100 patients. Is that right?
Yes.
Wow.
Yes. I started on September 1st, so almost 3 months ago. Started with just 35 coming with me from my prior practice, and I'm up to 108. Yes.
Wow. You're doing great.
Thank you. Yeah, I think we've really struck a chord in the community, so we're very, very grateful.
I would imagine so. And I always ask physicians why they went into medicine, but I think you chose it because your grandfather was a primary care doc. So Aimee changed my mind.
Yeah. I mean, he was. I mean, I very much understood at an early age the sanctity and the meaningfulness of the relationship that a person has with their doctor. And my grandfather was a primary doctor. And so, from an early age, you just see this person and the relationships he has with others as being really meaningful and deep and trusting. And people really listened to him, and his opinion was really one of honesty and compassion. And they looked to him for obviously scientifically based opinions, but I just knew that was the kind of person I wanted to be in whatever capacity. I mean, it sort of ebbed and flowed, and for a while there, I wanted to be a teacher for a lot of kind of the same reasons. I think sort of the impact you have in people's lives, but then I realized quickly that my love for science too could take me in that direction. And all of the people that in my life that have had that type of mentorship have been incredible physicians. So I think it was just looking at the kind of person I wanted to be, and then realizing they were almost all, physicians that when I wanted to emulate. So yeah, that was.
The best physicians are also educators. My dad was an educator, along with being a writer and a
Yeah.
public speaker and a business owner. And so you've combined two very important skills. You not only are doing diagnostics, but, well, okay, your grandfather was in a system that enabled him to do great primary care. Now, very different from what we have now. And
Very much so. Yes.
the really good news is that you're getting back into that. But there's something else that I noticed, and that is your husband's an ER doc. So did you work in an ER, like medical school? Is it required in your training?
Oh, yes. Yeah. We did a lot of ER shifts in residency as well. Yes.
Okay. So is that true for all docs?
Yeah, for the most part, everybody in medical school, I'm actually ER or emergency medicine is a fairly new specialty. So it wasn't a required rotation in medical school until just recently. So that people are getting more experience, but in a lot of residencies, your first year as an intern, you'll do a lot of ER shifts to kind of get a real good scope.
Baptism by fire.
Exactly.
Here's a little story, and this comes from my Twitter feed, and I had a funny thread about what grosses out ER docs. It was not what I and other people assume. And I've heard for decades now, always put on clean underwear every day just in case you wind up in the ER. But I find out on this thread, but you know what? It's cut off and bagged, and it goes away. What was number one on the hit parade? unkept and
God.
unmanicured toenails. It cracked me up. And so, I mean, was that true? I mean, from your experience or your husband's experience, did he ever?
Oh, it's unusual what kind of grosses you out. I mean, for us, actually, we both really don't like eye
Mm,
injuries. So, like eyeball
oh,
things. And so eye emergencies for him really just strike a chord. He can do gross toenails all day, every day, and he can do everything else that he likes, abscesses, all that. He loves all that stuff. But yeah, eyeball injuries, no good.
it's a special breed in the
Yeah,
ER, boy. And I,
it
I
is.
could
Yeah.
tell that from the Twitter feed because I almost don't want to say what won the special award, but I will. And it was toe cheese.
Yeah.
So, what is the backstory of starting your practice, which is called Health and Healing DPC? What's the backstory? What happened there?
Yeah, so I was part of the big system, as you mentioned, for the last 8 years, and with a big HMO system, and then with an academic institution the last couple of years. And it doesn't take long to realize that what you were trained to do, you have very limited capacity to apply in your actual practical life. You see about 25 to 30 patients a day in a busy primary care office. You really have limited ability to take care of multiple problems. I mean, the complexity when it's somebody who's very complex requires a lot of time. You just can barely scratch the surface sometimes during your visit. So after many years of that, you start to feel, the classic signs of burnout, which is the futility and just the what am I doing and am I making a difference, and the depersonalization of patient care. And so I think for a while, you sort of translating that into, okay, I just can't take care of patients. It must be the patients. And so then that's why a lot of docs will go more the administrative route or the academic route and become teachers to get out of patient care. What I what I learned about direct primary care from a former colleague, and I just thought that's just genius. I mean, the fact that we can see, you know, have a smaller panel of patients and be able to utilize all of the training that we acquired with it, which is a lot of mental health, a lot of counseling, a lot of education, um, a lot of sort of coordination of care, be able to utilize that with the time that you're given is really the genius in that model. And so seeing that even just in the first 3 months, the time that I'm allotted with these patients, like I've realized it's never was patient care that burned me out. It was the system that burned me out. It was I'm learning to love my patients again and learning to love the patient care part of primary care. I mean, I wouldn't have done primary care if I didn't love
Hmm.
people. And I'm learning that, it was never their fault. It was never the patients. It was the way we were practicing and imagining that we could take care of complex disease states and multiple problems and lists of problems in a 6-minute visit. I mean, there's just no
It's
way
like
to do
speed
that.
dating, but no,
Yeah,
wrong.
in a bad way. Yeah, in a
You,
bad way.
you
Yeah.
and Doctor, one of my previous guests, Doctor James Tinsley, was out in Newport News. One of the things that he said, and he loves this. He's doing the same thing, same business model. And I said, "You're living your purpose again, aren't you?" And he said, "Yeah, yeah."
Yeah. Mhm.
And I define purpose as the reason you exist. And I think physicians, doctors are very lucky in the sense that from a very early age, usually a lot earlier than some of us, you discover what your purpose is. You've got a pretty good idea. And if you're going through medical school and then residency, boy, that's living your purpose and you're on your way. And I can't imagine what it's like to go into a system and then have it corrupted over time. And I always say to people, keep in mind it is the system, not the doctor. Always look at the system
Right.
first. If you're going to complain, always look at the system. And this goes back to
Mhm.
business 101 with W. Edwards Deming back in the 70s and a lot of people have to Google that one. But he's the one who turned Detroit around to some extent, and bringing
Mm,
quality and understanding that with more variables means your line slows down, and any production line worker can tell you that. But
mhm.
for those who are wondering about what direct primary care is, how do you explain it?
Yeah, I think I basically tell people it's really a throwback, to how we used to care for patients 30, 50, 30, 40 years ago, where the patient doctor relationship is really back at the forefront of what's important in the office. I mean, the office is now run basically on the priority is the patient and our relationship. And so um, it's really the payment model that's different. The payment model is the patient or their employee or their employer sometimes, but most of the time the patient will pay a monthly fee to be a part of a practice, and the practice then now is accountable to the patient. And we don't take any insurance, so we are no longer accountable to any third party payers. We don't have to do any sort of referral systems or go through any prior auths usually, and so we can practice medicine in its purest form, which is doing what's best for the patient.
Hmm. And you mentioned something earlier, and I made a note of it, and that you mentioned patient panel size. And for those who are
Mhm.
not, I know what that is, but a panel sign
Mhm.
is another way of saying how many patients you have in your as a client list. Okay.
Right. Exactly. And so, like in a typical, my prior two practices, I had anywhere between, 2 to 3,000 patients, at a very, when I was very busy, but typically around 2,500 is an average primary, full-time primary care doctor And so, you see about 1% of your panel a day. So that's about 25 patients a day. And a direct primary care practice, it's about 5 to 600 total. And so that's about 5 to 6 patients a day. So it just gives you a lot of that extra cushion for time for the complexity, and then for the same day visits, for people to, for the phone calls, for the coordination of care, all the things that we aren't able to do in a typical insurance based practice.
You just mentioned coordination of care, and I know how important it is. I think in one of your videos, you mentioned that you worked in a high risk clinic where
Mm.
coordination of care is important in that setting. So, explain for those who don't know what that means, because that is really an important attribute for great care.
Yeah, there's so much. Yeah, they're exactly right. There's so much behind the scenes that as a primary doctor we really should be doing, and that's really calling specialists, making sure people, I mean, as in the office as well. Obviously my nurse helps with this too, making sure the patients show up for their appointments and then getting those notes, and so that we can review the notes. There's a lot of, I like the coordination for me is talking to family members too. So when I talk to a patient, sometimes I'm getting a third of the story, and so I'll get their permission. Is it okay if we, I call your husband, or is it okay if I call this friend that was there with you at that time, and I get their permission, and then I get so much more context. And, so I think that coordination, and a specialist coordination with any procedures that you may order to make sure patients know where they're going, and what their instructions are meant to do. And then also just the context, the psychosocial context to their care, getting the kind of it gives you so much more a broader scope of what the patient's dealing with, what they're going through, and you don't, because your job isn't done when they leave. A lot of there's so much more behind the scenes that you need to kind of fill in the gaps and make sure that things, that the orders will get executed, that they'll do what they're meant to do, et cetera, and that they understand what they're supposed to do at the end of the day too.
Hmm. Yeah, and it makes sense. It's a key attribute of great primary care. And I suspect your grandfather would be nodding his head at that and none too happy that it's almost
Yeah.
gone now.
Yes.
And
Yeah.
I have DPC here in Panama where
Hmm.
I live. And had I not moved to Panama, I would never have gotten into this. It was the ability to hear other people's views of healthcare, like my friends from Spain who tell me about their care, which is completely different than in the United States. And so therefore you have expats getting together and they'll compare notes, and the Americans will be, well, you've got waiting times and your healthcare is horrible and blah 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 and death panels and whatnot. And the
Right.
people in Spain will say, no, our healthcare is really good, but they're talking about two separate things. Americans have
Yeah.
access to, we have great specialty care and we have terrific catastrophic care. In Spain
Hmm.
in 1986, they opened their first primary care clinic, and now they have something like over 13 or 14,000 as of 2006. So they focused as a nation, they focused on primary care. And you alluded to something that I think escapes a lot of people, and that is the mental health aspects of care. And if you've only got
Hmm.
6 minutes or 10 minutes or even 20 minutes, but part of that time is what are you doing? From in the old system, you're on the computer, aren't you? You're on
Right.
EHR.
Exactly.
How does how does and I already know the answer to some extent, but it's good to hear it from a healthcare expert because you have an MD after your name and therefore you're a healthcare expert. how does how
Hmm.
does that mental health aspect um, I asked Dr. Schimpf about this, and he said, "Yeah, it's real easy for a primary care physician to just to spot problems, mental health
Hmm.
illness, or there are issues. You're a trained medical observer. That does not mean a primary care physician is going to be the one diagnosing it. It just means that you can spot things and tell me I'm wrong or refine my thinking, but." It seems to me that you're in the ideal position to be a good tripwire.
Hmm. Oh, yeah. Very much so. I mean, I think, well, the fact is that 80% of mental health is dealt with in the primary care setting in the United States. And so, whether or not we like it or whether or not we feel like, I mean, it's there. People come to us. They don't, either they can't get in to see a psychiatrist or a mental health provider, or there's a lot of whatever sort of, if there's any internal shame or privacy issues, they're concerned. So they come to us. And so, we're very well trained in the clinically how to diagnose a lot of depression and anxiety and other mental health diseases, but then we end up really treating. The problem is these these issues aren't just they are never a 6 minute visit or even 20-minute visit. There's deep seated issues that then resurface years later as anxiety disorders or major depressive disorder or post traumatic stress disorder. And so, even though we are seeing it, we aren't we don't have the adequate time to really dig in and help these people. And we are in a crisis of addiction in our country. We're in a crisis. I mean, our kids deal with more kids deal with anxiety now than they ever did, in the last several decades. And we see it, and it's just bursting at the seams. And it's what's hard is that in this system, what we end up doing is just referring out, over prescribing medications that may or may, maybe they're indicated, but we don't have the time to really dig in and find and surf, sort of dig into the deeper problems as to where this is coming from and deal with lifestyle issues, behavioral issues, coping strategies, um, cognitive behavioral therapy, which we can do
Mm-hmm.
actually, but there's just no way. There's no way. I mean, we get the training, we just can't do it in this system. Um, and if you don't treat the mental health, I mean, nothing is going to get done. I mean, that patient's not going to take their blood pressure medications. They're not going to go start working out. They're not going to quit smoking. They're not going to do all the things that you want them to do for their physical health because their mental health isn't optimized.
Right.
So it's such a crucial piece of of the whole pie, really.
For someone who is hearing about direct primary care for, in the last, let's say, year or so, it's getting more traction. And there's probably over 1,000 doctors now that have clinics like you. What's the difference between the comprehensiveness of primary care the way you do it? How would you describe the difference between the old and the new?
Oh, I mean, just because I do have the time, and I can really sit back and I can say, well, let's talk about that. Where does that come from? Let's come up with an action plan. Let's work on these behaviors. Let's talk about maybe some cognitive behavioral therapy, talk about journaling. What do you do to meditate? What do you do you pray? All these other kind of endogenous ways that you can boost serotonin in your life. I mean, I can talk about a lot more lifestyle, and we can get into some of the core issues that maybe haven't been dealt with for years, um, and see them. If I need to, I can see them every week and not worry about administrators telling me that I can't book them in that slot because that we are having open schedule, open access system, or worried about putting any sort of other restrictions administratively that you can't when you don't have the flexibility. I can also do phone visits. I mean, because a lot of insurances don't pay for telephone visits, that whole issue is removed. So I can talk to them on the phone. I can text them. We can, if they agree to that type of communication, just that we can keep the accountability and the sort of plan going. And those things you just don't have capacity to do because you're just in the old system. You're seeing 20, you're just barely finishing your notes at the end of the day for your 25 patients. So there's no way you can spend an hour on the phone with, the depressed patient you saw last week.
And does the system doesn't allow, well, let's put it this way, the system doesn't pay you uh, unless the old system doesn't pay you unless the patient's sitting in front of you.
Yeah, it's a pretty yeah, that very much begets a very big brick and mortar inefficient system. I mean, there's not really at this point there are some codes that allow you to get reimbursed, but they don't pay well. So there's just no incentive,
Yeah,
and they're long visits. So if you spend an hour on the phone with somebody, that's a
yeah,
lot. You can code for time, et cetera, but it really isn't the same as you could have seen 4 patients in the office that day and been paid a lot more.
right.
So the incentive is not
The
there.
system once again. Yeah.
Hmm.
So if I'm living near or in Woodland Hills in LA area, and I see an ad or I see you on TV or something, and I make an appointment to see you, and I want to know more. What do you wish I knew before you met me for the first time as a potential patient?
I think what I wish people knew coming in is that there's a little bit of there is very much in LA. There's a lot of concierge doctors. There's a boutique medicine, a lot of concierge, and I do think there's a disconnect, and the people think, oh, just kind of doctors trying to get more money. And I wish that people would understand more about direct primary care and how it is distinct, and that this really isn't about getting just kind of a cash grab. It's really to break away from a broken system, and that you know what we're trying to do is to be able to provide better primary care, at an accessible, affordable cost. And so that's kind of, I guess, the distinction I wish I could get out there is what direct primary care is versus concierge. And concierge, there's nothing wrong with concierge. I think that fits certain people's needs.
Hmm.
But I think direct primary care is trying to fill another void of people that are just stuck in a system of broken primary care. They can't get an appointment. The access is terrible. When they're there, they get rushed. It's a 6-minute visit. They don't know what's going on when they leave the office. They have 16 questions when they get home when they can't call their doctor. And that's just a broken system. And that's kind of the aim of direct primary care, is to just make it make it a better
More
experience.
access, and what you just described fuels Dr. Google, and
Right. Exactly. Right.
I said that I have direct primary care, and I'll give you an example. Earlier in the year, I was working around the house, and my foot started hurting. and it was sudden.
Mhm.
And I thought, well, what's this? You know, it's like I strained and I wasn't doing it. I wasn't working out or anything. I was just walking around. I was walking barefoot on tile floor. And I went on Dr. Google. And I think the third result down said, you need to go to the emergency room. You're probably having a heart attack or stroke, whatever. And
Yeah,
I'm like,
right, right.
well,
Oh,
wait a
jeez.
minute. No, I have a direct primary care doctor. I think I'm just going to ask him. So WhatsApp is very popular here. So I sent him a chat and I said, Doc, I've got this, and what do you think? And he got back to me 5 minutes later and said, have you been standing around? I said, no, I've been, told him what happened. And he goes, okay, it's probably plantar fasciitis. Is that right? Okay.
Mhm.
And
Yeah.
he says, it's
Mhm.
this, it sounds like this. And what I want you to do is go here. I'm going to go get 10 of these pills, take 2 a day for 5 days. And if this
Mhm.
happens, let me know. But otherwise, after 5 days, you should, be good to go. And then you should probably go online and look at physical therapy things that you can do to reduce the likelihood of it coming back, or at least just physical therapy. And he was right; it was spot on, and I didn't have to go anywhere. And in 10 minutes, it was dealt with. And that's a huge relief, especially traffic. I mean, I know
Yeah.
LA traffic has got to be just,
Yeah.
if it's anything like, well, Panama is now
Yeah.
just as bad, I think. And there's
Oh
no
my
lane
gosh.
discipline either. So, hello. So I think one big disconnect for people who have health insurance is I already have health insurance, so why would I pay extra for DPC? Now, I know the answer to that because I have health
Yeah.
insurance, although it's catastrophic care or um, what we used to call major medical. So
Mhm.
when someone says, well, I already have insurance, why would I pay you more? I know it's the care, but what do you say to them?
Yeah, I think right there. I think it's one of two things. Like you mentioned, some people really just think of it as I'm paying because the access is better and the care is better and all of the communication is better. But I do think that the other piece of that is that actually, if you look annually at what you spend, if you have your insurance plan, you're paying for it. It's just bundled in these huge premiums. So you just it's and if you look at your premiums and if you do make some adjustments and you do get to exactly what you're doing, which is a more high deductible plan, or what a lot of my patients do, like cost sharing plans, you can really save annually, sometimes thousands of dollars, by having a direct primary care plan and changing some of your benefits. So you have to kind of look at the whole thing, even though you have insurance. I mean, insurance, unfortunately, it's transitioned into the primary payment model for all of our healthcare utilization. I mean, we're paying for like $4 medications and we have a $25 copay. Like, what does that? Doesn't make any sense. So we're using it as a payment method, and it's consequently really raised the cost of healthcare expenses, and then thus the next year the premiums go up. So people have a really hard time ponying up more money, but they have to shift their paradigm. They have to shift their thinking and realize what insurance is for. It's there to protect you financially and to prevent any sort of financial catastrophe from a medical event. It's not really there to pay for low cost primary care. You can do that if you just reduce your premiums and you go to a high deductible plan, then you have plenty of money left over to pay a $89 a month primary care doctor. I mean, it's sort of it's a big paradigm shift, especially for people in this country.
Yeah, boy. I think what people may start catching on to is the fact that, and you alluded to it earlier, and that's the personalization of medicine, personalized care. But
Mhm.
the definition of that, my definition of it is, and it's something that I'm sure you're seeing more of, there's more variables coming into care. You have more tests. You have more. You now have genetic tests, which are under $1,000 now for a complete genome,
Mhm.
and heading towards 100 fairly soon. You also
Mhm.
have an explosion of medical data You have wearable devices, so you have a lot more variables coming
Mm,
over the transom, so to speak. And that's something that I think any auto worker, any assembly line worker, anyone who works in a systems, even a bartender or a waitress, would
mhm.
understand that. Look, if you've got 5 bottles of liquor on the wall in your bar, you're not going to be able to make that many drinks. So therefore,
Mhm.
your processes are not the time it takes to make something. It's pretty quick. But you add
Mhm.
300 bottles, and all of a sudden, the variables go up. Uh, you're going to need more bartenders, and the line
Right,
slows
right.
down. And
Yeah.
so, you as a primary care physician, it follows that you have a lot more variables now to deal with, and
Mhm.
you need more time with the patient. And the old
Mhm.
system doesn't do that, does it?
No, no, there's a lot. Your and patients come in very informed. I mean, I think in the system, that's a burden. When the patient comes in with their Google search already printed out and they tell you what they have, in the old system, I would kind of sigh and go, gosh, okay, this is gonna be, because I'm having to unravel. And then now I feel like because I have the
Hmm.
time, we can sort through that together. And sometimes they're not always wrong. We can sort of go through what they think it is and what their Google search turned up, and then based on my obviously education and current evidence-based medicine, like what I think the situation is, diagnosis is, and what the next steps are. I mean, we're here as partners, and I think in the old system, it's sometimes easier to be paternalistic and just say, and then if your people don't do what you want them to do, you get frustrated, and that leads to burnout. But in this new system, I think there is more room, especially with the advances of technology. There is more room for partnering and shared decision
Hmm.
making.
I'm really happy to see businesses are catching on to DPC. I mean, that's a cost savings tool.
Yeah.
And it's an easy
Yes.
one to measure, though.
Absolutely.
I mean, that part of it is easy to measure, but the hidden benefits of DPC and what it brings business owners, they really don't know what to look for, at least in some of the things that I've been reading. Um, some of I don't know how many, if you've got any businesses signed up, but boy, if I were a business owner knowing what I know, I'd be all over this.
Right. I know. And I think that Southern California is sort of new, like naive to all this. So I think they're very ripe for the education. There's so many small businesses out here. A lot of folks that are, in the industry even that own small businesses or own production companies, et cetera. And it's that you don't have to scratch the surface very deep to realize the benefits. I mean, it's obviously the health benefits are, patients have better access to care, they can have more efficient care, they can call, they can text, they don't have to have as many sick days, they don't have to take a whole day off to go see the doctor for 6 minutes. They can, whatever it may be. So the that's a real benefit. But then even just the in-house prescription dispensing, there's a lot of we advocate and we try very hard as direct primary care doctors to have really good prices for radiology tests, for labs, for prescriptions. So in general, right there's a lot of cost savings for employers if they do partner with a direct primary care practice because they can just is a lot. There's a lot of cost savings too.
Well, also for individuals, I mean, I've heard stories. Dr. Tinsley mentioned something. He had a patient that needed life saving. They had a kidney transplant,
Mm,
and he got $900 worth, a month's worth of a prescription, $900, and he got it for 90,
wow.
and that essentially paid for the bulk of that member's
Of
fee,
the full
yeah, for the
membership.
year.
Yeah, absolutely. And I think yeah, I'm learning how to tell people that, I just give them a medication. I go, that'll be $1.30. And then, but I'm forgetting the other part of it, which is like, that would have been $36, so you have to be kind of, a little more transparent because we do. And I think that's what was really an easy sell for me. I wanted to do something off on my own. I never liked the concierge model. I love that direct primary care is really pushing price transparency in healthcare in general, and they're just involved in a larger movement to make costs more transparent so patients can be, employers can be better consumers of healthcare, and surprise billing in general. I think so. I love that. We're also not doing, we are taught and we take our Hippocratic oath to do no harm, but we also need to stop the fiduciary harm that we're incurring on our patients.
Yeah. Yeah. I mean, you mentioned Hippocrates and the Hippocratic Oath, and that, I mean, that's 2,400 years ago. And one of the things that I'm concerned about, and I wrote about it in my upcoming book, is the expectation of privacy between the patient and physician, which is within part of what Hippocrates said, that whatever a patient tells you is private. So if I'm telling you, hey, doc, I have this, my expectation is it goes no further than you. And so when did you first hear about this in your medical education? Was it sort of an, oh, by the way, or did they pound it into you in medical school, or was it somewhere else?
I mean, I went to Thomas Jefferson and in Philly, and it is still a very clinically oriented training. They have some of the highest percentages of graduates still practicing clinically. So they, very early on, they teach about the sanctity of that relationship. People are coming to you in a very vulnerable state, and so the privacy part of it is huge in that sacred space, that they are coming to you in a vulnerable state, and the reason why they're able to open up and tell you things is because they are assuming, whether or not it's stated outright, but it should be, but they are assuming privacy and the integrity of that relationship to remain. So that was a very early on in our training, and I really love that was, sort of old-fashioned medicine is still being taught that way early on to medical students, because I remember one of my mentors saying, there's a reason why employers and teachers and people still ask for a doctor's note, like your note means something. That signature means something. It comes with integrity and honesty. And so don't take that lightly. So I think that the privacy in direct primary care is even more so because there is no third party administrator coming in and trying to get data. We don't have to, that exam room can remain the sacred space it was always meant to be.
What happens to medicine and care without the privacy?
I think it's diminished and deteriorated. I think that we have messed up in the past as in our profession in terms of medicine and research, and even in some cultural groups, there's a lot of inherent distrust in our system, and the burden is on us to make sure we contain and remain that integrity in our relationship, and a huge part of that is privacy and saying it outright. I see a lot of pediatrics and adolescents, and they have to know from the very beginning, because they have sort of this natural distrust in systems, which is a beautiful thing. It's good for them to be questioning. But I have to say outright in the room when the parent leaves the room, this is private. What you say stays here unless I feel like you're at risk to yourself or others. I cannot, based on the oath that I took, 11 years ago, I can't say anything to anybody, especially your parents. And that's so important, because then people can open up to you and tell you things that they probably would not have said otherwise.
Yeah. So, there's a potential train wreck that I really don't want to contemplate, and it's not good. But getting back to health and healing, and it's health and healing direct primary care, right?
Correct.
Is there anything
yes.
a potential patient ought to bring with them before meeting you, or any new physician, but for the first time?
I think they just, an open mind. I think I really just want them to know that I'm here for the long run. This is not an urgent care or acute care visit, even though you may have an issue that's going on right now that we'll handle. This is a relationship that we're going to be building over time, and that I'm here. And I'm so grateful for this model, because I do think without this model, I would have gone the
Mm,
way of many burnt out physicians, administration, urgent care, telemedicine. There's nothing wrong with any of those in particular, but that's not why I became a primary care doc. I wanted to create relationships. So when I see patients for the first time, I want them to know that I'm here, I care, and that this is for the long term.
sure. Well, direct primary, the business model is what enables you to have more time with the patients. And it also enables you to be, I mean, people are so used to going to the doctor and sitting in front of them and they pay when they're there. But you're also thinking about them when they're not in the room.
Yeah,
Um,
right. Oh yeah,
And you
definitely.
get that, but that membership fee enables you to get compensated for your time. And most people won't begrudge that. They'll say, yeah, my doctor's worth
Right,
that kind of time. But oh, you're going to be thinking about my genome and my gut microbiome and what I need to
right,
do. I mean, that is great care. And for the money,
right,
it's dirt cheap. So
right.
for listeners nearby in Woodland Hills, world famous Woodland Hills, check out healthandhealingdpc.com, or if you're far away, go ahead and check that out. There's a lot of good information on your site, your Facebook page too, and we'll link to it in the show notes on our website at winhff.com. And Dr. Aimee Ostick, thanks so much for joining me, and I know you're going to be very successful.
Oh, I appreciate that. And I'm just so grateful to you for pushing out this message and educating people. And yeah, very blessed. Thank you so much.
Thanks for listening to the Winning Healthcare Food Fight Show. Hit the subscribe button to hear more expert thinking on getting better care without the mess.